I'll start. So I'll be presenting on allogenic CAR T in relapsed refractory large B-cell lymphoma. So there is a study which is published on Journal of Clinical Oncology. It's called Alpha 2/Alpha clinical study. They used a product called Cema-cel. So it's semacaptagene and secreclucel. So they have renamed it as Allo 501A and Allo 501. So I'll be presenting on the phase one experience of this study. So, for the background, there is an unmet need in large B-cell lymphomas, with 40% of the patients relapsing after first-line therapy. But with relapsed disease, the median overall survival is around only 6.3 months, with a 2-year PFS of only 20%. So, autologous CAR T cell has its own limitations. Actually, even though autologous CAR T cell has revolutionized the treatment modalities in these patients, it has its own limitations. So, for example, they include manufacturing delays, which require at least an average of 20-21 days for manufacturing. And there is a requirement for bridging therapy. Also, the product quality varies between patients because depending on the harvest and many other factors. But in this context, allogenic CAR T has its own advantages. So, for example, it includes we can take the cells from healthy donors, and we can have a standardized manufacturing. So we can determine how much dose goes into each of the bags or how much dose goes to the patient. And it has off-the-shelf availability, so we won't be needing for waiting for manufacturing delays or bridging therapy, and there is no need for leukapheresis for the patient. So this study is had used actually they had used totally three products, which I have made 1, 2, and 3. So the first product is Allo 501. Allo 501 is an allogenic CAR T product against CD19, and they had revised and made another new version called Allo 501A. So the difference between Allo 501 and the Allo 501A is the presence of an rituximab sensitive domain. So for all intents and purposes, they had considered these two as the same drug. So they had used it Cema-cel slash Allo 501 everywhere in the study. And another product which they had used is something called as Allo 647. So Allo 647 is an lymphodepleting agent. It is an CD52 monoclonal antibody, which is designed by the same study group. So, they had used this in combination because the study mentions that compared to autologous CAR T cells, allogenic CAR T cell therapy might require more or stringent lymphodepletion. So they had used anti-CD2 monoclonal antibody, which is Allo 647. So it helps with more stringent leukodepletion. And along with these two products, they had used this Allo 647 at 13, I mean, three different dose levels. So they had used it along with fludarabine and cyclophosphamide. So in one arm, they had used fludarabine and cyclophosphamide plus 13 mg of Allo 647 for 3 days. And in the other arm, they had used it 20 milligrams for every day for 3 days. And in the third arm, they had used it 30 milligrams every day for 3 days. And they had also planned a phase 2/3 for this same products, in which they had included the people. They had studied the consolidation with the same product, Allo 501E, and they had taken people from the 20 mg into 3 days arm. But those people had gone to consolidation. So if we see the study flow chart on the left side, lower left diagram, so there are these three cohorts that include FCA 90 stands for fludarabine cyclophosphamide plus A90s, Allo 647 at 90 milligrams. So 90 milligrams as in 30 milligrams daily for 3 days. And which is post this lymphodepletion, they had given the product Cema-cel slash Allo 501. So in another arm, they had used FCA, that is fludarabine cyclophosphamide, plus this Allo 647 in three doses of 13 mg, which is followed by Cema-cel or Allo 501 infusion. And the third arm is same, 20 mg for 3 days, with followed by the Cema-cel infusion. So the picture on the lower right is for the second phase, like how they were trying to consolidate the patients who got response and they had used only the dose level 2, which is 20 mg for 3 days of Allo647 arm. It is a little bit confusing, but yeah, as we go, okay, it will be easy to understand. So the Cema-cel slash Allo501 is a second generation single chain fragment variable fragment with murine CD19 with 41BB co-stimulatory molecule and a CD3 zeta signaling domain. So the Cema-cel and Allo501, they are similar except that Cema-cel or Allo501A had an additional rituximab recognition domain. So and up to avoid GHT as well as to avoid alloimmunity, they had knocked out two genes. So one is the T receptor, T cell receptor A, and they had also knocked out CD52 because they were giving anti-CD52 monoclonal antibody as lymphodepleting regimen. So Cema-cel has an additional rituximab recognition domain, and they had a manufacturing setup in which they could manufacture 100 doses in a single run. And monoclonal antibody against CD52 is Allo647, and it allowed for enhanced leukodepletion, which was required for allogenic CAR. And they were testing it at three different dose levels: 13 mg in 3 days, 20 mg in 3 days, and 30 mg in 3 days, along with fludarabine and cyclophosphamide for leukodepletion. So the study design is a single arm, multi-center study, and they used CAR-T relapsed refractory large B-cell lymphoma patients. There were 33 patients, and the lymphodepletion was, as I said above, and they used Cema-cel or Allo501. And the endpoints they studied, the primary endpoint was safety, dose-limiting toxicity as and maximum tolerated dose, and the dose for recommended dose for phase 2. And the secondary endpoints were efficacy mostly, and it, on the basis of overall response rate, complete remission rate, duration of response, and pharmacokinetics and pharmacodynamics. So the patient characteristics, median age was 66 years, and all patients had received a median of 3 therapies prior to this study. And patients are in the ECOG category of 0 to 1, and 21% were in ECOG 0. And 67% of the patients had high tumor burden, which they had defined as LDH more than upper limit of normal, and 30% which were double hit or triple hit DLBCLs. So this is the detailed patient characteristics. And if we see, patients were naive for CAR-T, but they 7 patients or 21% of the patients had undergone HSCT before, hematopoietic stem cell transplantation before. So the treatment schema will be it was lymphodepletion from day -5 to day -3. So as we said, fludarabine and cyclophosphamide were common for all 3 days. And Allo647, the monoclonal anti-CD52 antibody, was in 3 different doses. So 13 mg for 3 days, or 20 mg for 3 days, or 30 mg for 3 days. And this was followed by a single dose infusion of 120 into 10 to the power 6 CAR cells. They had not mentioned the dose in per kg for the patient's weight, but they had given a single dose of 120 to 10 to the power 6 CAR cells. And for phase 2, they had kept the consolidation. So people who get stable disease or PR, partial response or complete response, on day 30 after disease assessment, on day 28, they were given consolidation therapy. I'll tell about it in the upcoming slides. So the efficacy results, so the overall response rate was 58%, and the complete response rate was 42%. And the maximum response rate was observed in the FCA 90 lymphodepletion regimen, where the Allo647 or the CD52 monoclonal antibody was given at 30 mg for single day, 30 mg for 3 days individually. They had a better overall response rate compared to the baseline overall response rate of 58%. FCA 90 regimen had overall response rate of 67%. And duration of response was overall, a median was 11.1, in patients who achieved CR, they had a prolonged duration of response of around 2 years. And a 12-month CR durability was around 60%. And patients who achieved complete remission had better OS with the median OS not reached, and median PFS was 24 months in patients with who achieved complete response. So this is the duration of response, and which is almost equivalent to the PFS curve and the OS curve. So overall survival, and they also had a good PFS, and they had prolonged duration of remission or duration of response. And people who achieved partial response, they had a poor PFS and poor DOS, and they had relatively lesser overall survival. And by subgroup, people who had tumor burden less than 1,000 millimeter square, which is the uh, sum of all the measurements of the lesions, that they had an overall response rate of 100%. And people who had less bulkier disease with LDH lesser than or equal to upper limit of normal had a better overall response rate. And double hit, triple hit had around 75% of overall response rate. So this is the subgroup analysis curve. So if we see the main differences were there in baseline SPD row, where the total dimensions of the tumors, the sum of the dimensions, where if it is less than 1,000 millimeters square, they had good response. And people who had germinal B center, they had poor response. Who had non-bulky disease had better response. And regarding safety profile, there was no cases of GVHD, and we had ablated that, knocked out the gene which was responsible for that, and there were no cases of ICANS or no cases of more than grade 3 CRS. And the common adverse events reported were neutropenia, anemia, and thrombocytopenia, mostly hematological. And CMV reactivation was seen in 30%, with grade more than 3 in 12%. And also the study mentions other reactions, including infusion reaction, fatigue, and constitutional symptoms. And cytokine release syndrome, grade 1 to 2, were seen in 24% of the patients, and none of them required tocilizumab. And the median onset of cytokine release syndrome was on day 5 post infusion. And most of the infusion reactions were to Allo647, the monoclonal antibody, and it was 9%, and 6% were serious. And coming to cellular kinetics, the peak expansion day was on the 10th day, and the expansion was more in the 90 mg Allo647 cohort. So we already saw that the response was higher in the cohort which received Allo647 at 90 mg. And the cells were detectable, CAR T cells were detectable up to 4 months. And patients who responded, they had higher AUC and higher peak expansion compared to those who didn't respond. So if we see, they have combined these charts. So on the upper row, they had mentioned, they have depicted the neutrophil and lymphocyte kinetics. So the peak neutropenia was seen around day 7, beyond which there was a gradual increase or recovery. And the peak lymphocyte count was nadir was seen at day 0, and it progressively reached near normal levels at 1,000 per microliter at month 9. So the CAR T expansion kinetics show around in non-responders, the duration of CAR T expansion or persistence is lower compared to the responders, and the peak was seen around around the second week. So regarding allogenic CAR-T. So, donor-specific antibodies were tested in all
barely audible,
patients
Dr. Naveen.
had
Uh,
DSA more than 1,000. They have not but they have mentioned that antibodies, while the other patient had progressive disease. And matched product and alleles now. Hello,
Hello, Dr. Naveen,
hello.
your voice was cracking for this whole slide. Can you repeat this one,
Yes, ma'am. Am I audible now, ma'am?
Dr. Naveen? Yeah, you are
Hello.
audible now. But this slide we just couldn't hear anything. Can you repeat it?
Okay, ma'am. Yeah. Uh, so they had done HLA analysis using DSA and HLA matching in all these patients, as this was allogenic CAR product. So DSA was tested. Donor-specific antibodies were tested in all 33 patients, and two patients had DSA more than 1,000 MFI. And they have not mentioned how they dealt with the DSA, but they have mentioned that despite DSA positivity, one patient achieved complete response and another patient had progressive disease. And HLA matching was also done with the CAR T product and all the patients. And no patients had more than 3 by 10 match, HLA match and outcomes. So they have given an example that two of the responders had zero matching alleles. So, and they when they assessed the impact of lymphodepletion, so allo 647 exposure, it correlated with uh, high IL-15 levels at D0, and it also correlated with CAR T expansion. So people who received FCA 90, that is fludarabine plus cyclophosphamide plus allo 647 at 90 mg, 30 mg into three doses, they had better CAR T expansion and also had high IL-15 levels at day zero. And for all patients, T cell recovery post lymphodepletion occurred around 6 to 9 months, as we saw in the chart. This is the uh, CAR T expansion kinetics as well as the, based on the allo 647 dose. So people who received allo, the red curve is people who received allo 647 and 90 mg, they had a peak CAR T expansion. So, and regarding the infection profile, CMV reactivation occurred in 30 percentage, and other around another 30 percentage had bacterial, fungal, and other viral infections. And there was no incidence of high-grade CRS or ICANS as we saw before. So this compared the efficacy of allogenic CAR T with the existing autologous CAR T cells, and the study claims that they have more had a median duration of response of 11 months, and this study had a median duration of response of 23.1 percentage. And how they hadn't had clear-cut comparisons. They just had study mentions that the median duration of response was higher. And also, there are, the study mentions some advantages over autologous products that they have median 2 days of enrollment to treatment, and there was no need for bridging therapy. And also the manufacturing efficacy that 100 doses could be produced per production run. And after the 100 doses were made, they had cryopreserved. They had kept an inventory of cells from which they can uh, provide off the shelf uh, dispense. And there was less risk of secondary T cell neoplasms compared to autologous CAR T, but there were no such statistical study or proof study. And also consolidation comparison to was not possible. In the phase 2, enrolled 12 patients in LBCL at 2020. There were 12 patients had achieved or complete remission. Those taken up for consolidate another dose. So the limitations were the study was of a small sample size and a single arm study, and the study had a shorter follow up duration of median of 10.1 months. And also, the study didn't include anyone who had received prior CAR-T and failed. And the study didn't mention about CMV monitoring or prophylaxis requirements. So, however, the study validates allogenic CAR-T platform, and it has also potential for consolidation therapy. There is this ongoing research phase 2 on consolidation strategies, and also the study mentioned that they have combination approaches with bispecific antibodies and PD-1 inhibitors. And again, the strength is the first allogenic carbon grade 3 or GVH, and rapid availability address the limitations of CAR-T, and consolidation strategy is merits further study. And there is a study they have mentioned that they are assessing cost or access considerations also. That is another advantage. Thank you.